So before I get started, I do want to say I have no conflicts of interest. I currently work at NIDA, and NIDA is my funder. I'm honored today to discuss this topic with everyone. And basically what we're talking about is something that we're doing using like passive data, digital phenotyping, computational psychiatry, whatever the word choice of the day. But using this as like an intersection of technology, healthcare, and behavioral science. And I specifically work with substance use disorder, and it's one of the most complex public health challenges of today. And one of the things that we found is that the emergence of digital tools like passive sensing and machine learning is giving us an unprecedented opportunity to approach this with innovative ways. So my hope today is that I not only share some insights of what we've been doing in some of these, what I hope are cutting edge technologies, but that I can also spark in everyone a conversation about how we can use these types of technologies in the development of treatments as well as development of measurement for people in substance use disorder and beyond. So the first thing I'd like for us to do, or I'd like the audience for you to do, is imagine a world. Just imagine a world where we can predict substance use disorder outcomes like treatment relapse or treatment dropout. We know that this is a very hard thing to do, but let's say that we can. And I want to say that I think we're very close. I think that right now, with passive sensing and also some active sensing like EMA, we can collect real-time data from the individual wherever they're at, whatever they're doing, whoever. We can even collect this data if they don't have Wi-Fi, and then have the data sent to us when they're on Wi-Fi. It gives us this opportunity to get people or what people are doing in real time, this moment-by-moment assessment, no matter where their location, no matter their SES, no matter their language, but we can gather this information. And this right here is just revolutionary. We've never had this type of insights into the day-to-day activity of a person's life. The other part of this is that since we can get so much information and tie it with other information, clinical information that we have from people, social media language, all this different stuff, it allows us to take this information and then potentially deliver it back to them to empower them with tools, with interventions, with also moment-by-moment, just-in-time types of information. We can deliver this to them on devices that they use and carry. I mean, we take our smartphones and our smartwatches everywhere with us. It goes into the bathroom with us. It sits next to us when we take a bath. I mean, it's everywhere, right? We now have access not only to what is the data coming in, but then being able to give people interventions with this. This right here is a new way of thinking about how we can help people with recovery and empowering them to make decisions that are appropriate for them. This innovation that we are working with in medicine, and medicine has always been driven by innovation. And today what we're witnessing is just revolutionary. I mean, we have a situation when you think about that you can put people in different environments with a headset, right? In an office, back in the day, you'd have to have like a whole room dedicated to this. And now you can just do it. You can even do it with their own smartphone and very low technology. It does not like to click. Okay. The other part about this is that these digital tools like our smartphones and our smartwatches, our at-home connected speakers, Alexa, a lot of us didn't really think or may not think about that Alexa is one of the first generative AI models, also Siri, that we've had in our house just living there that responds, is using generative AI. We can tap into those to deliver interventions as well as to gather information about individuals. And all of this, again, is just passive data. Now, if you combine all of this with compute power, with the compute power that we have now, the smartphone of today was the supercomputer of 1970, 1980. We're at the point now with the amount of compute power we got that we can really work and really get information and really mine this data, unlike what we've ever been able to do before. So here are two images that represent two sides of what we were talking about. When you think about, on one hand, we have treatment for substance use disorder, which is deeply personal, human-human connections, which is central to recovery, moments of support, giving people touching, human, in-person interaction. And on the other hand, we have an increasing world where we're getting this interaction through a device. Potentially, this device can give us have some of the same attributes that we get in person. We can train chatbots to be empathetic, to be like friends, to give some of this emotional support. But we can also have people in online communities and in digital environments that can also provide this humanistic support. Now, I will give a little bit of bias. I don't want a world where we're all connected to our devices and we don't have this interaction. I want a world where we can combine these things and we can make the best. I want a world where I believe in peer support. And we can make peer support better. That would be great for substance use disorders. And I think that what I'm excited about most is the advancement and the opportunity that we have today. The work that I just sat through the first symposium, the work that individuals are doing, and everyone else in this room that we're doing, we're at this area where we are making so many changes, and we have the opportunity to just move forward, especially with the amount of compute power that we have today. So in my lab, one of the things that we're working on is passive sensing, digital phenotyping, and using AI in substance use disorder. We specialize in transforming passive data into valuable clinic data insights. And by harnessing the power of AI, artificial intelligence, we aim to revolutionize the way that we understand substance use disorder. Not necessarily, working off what has been done in the past, but also doing data-driven approaches, not just theory-driven approaches. We incorporate behavioral insights, especially language. Language is, I say, my bread and butter, because it holds a significant key in identifying and addressing substance use disorders. Our approach combines passive data, methodologies, and traditional approaches. We prioritize the understanding of this dynamic, heterogeneous, and subjective experience of the individual. We prioritize that while also understanding the social and environmental factors. That's one of the other great things of using passive data from our devices, from online, is that we can get a lot of information about the environment that as a clinician we would typically not get in the settings when people are in the office. And our goal is to redefine treatment through technology. One of the key pieces is also making things accessible. We can make it language, vision, all of these things that we can do with digital devices that we may not necessarily been able to do before, as well as accessible for where a person is, as well as class, social economic status, things like that. There we go. So in my talk today, I'll cover some of the pressing challenges in SUD treatment and how integrating digital phenotype and machine learning can lead to predictive insights. We'll explore specific case studies and discuss some of the ethical implications, ultimately deciding and kind of thinking about how these tools can transform care with individuals who have a substance use disorder. So when we think about some of the limitations of traditional treatment, we have to understand that we are typically relying on episodic and self-report. When I think about, one of my first jobs was I was a substance use disorder counselor as well as did HIV counseling. When a person comes in to treatment, during that first time, that first week, we're gathering all this information about them. That is also one of the most chaotic weeks of their life, and we're asking them to recall a lot of what has happened before. I don't think that is a good time. What if we already had data when a person comes in about the last 2 years or the last 5 years based upon their smart device? We also need continuous objective monitoring. We need to know what is happening 24/7, or we'd like to know what is happening 24/7. And we'd like it to be objective, not their retelling of what happened and why they reacted a certain way. I mean, we may want that too, but we'd also like to have this objective, continuous measure. One of the other problems of traditional treatment is it's limited by the treatment services. The services which are offered, the type of the service location, and people's access to treatment services. We also have limited resources. We are in a situation where there are not enough counselors, there are not enough treatment providers for people with a substance use disorder. Counselor availability and time between sessions, counselors are not there, providers are not there 24/7 in the middle of the night, right? And also personalization, or the lack thereof of personalization. We've been working on a one-size-fits-all model, and we need to move past that. So what's the promise of passive data, digital phenotyping? I think the main promise is that we can get objective, real-time longitudinal data. It can be continuous as well as passive, meaning that it's being collected without the person doing anything other than living their normal life, their best day ever, right? We can also think about start being able to do treatment matching as well as treatment optimization. Is less costly to deploy, more costly probably to develop, but less costly to deploy once you've made it and maintained it. 24/7, year-round, is personalized. We can personalize, for example, the visual and the content. We can also personalize the language. You can write one thing and be able to make it for various different languages, as various different ethnicities and cultures. So one of the things I'd like for us to say is that we need to shift from being reactive to shift to being more predictive and more approaching substance use disorder, not from an episode of a person maybe overdosing, but thinking about how can we preempt some of these situations. So what is digital phenotyping? It's a word I've been using. A lot of people in this room probably know it already, but basically it's using this moment-by-moment passive data to quantify the individual level human phenotype, and using this data that is typically coming from smartphones, smartwatches, connected devices, social media language, and your online activity. What we do is we take this passive data, sensor data, things like that, and we combine that with active data, things like your EMA, to gain insights into the individual, which will hopefully allow us to understand more about the risk factors that lead to substance use disorders or that leads to relapse treatment outcomes, things like that. So thinking about kind of the history of digital phenotyping, many of the people in this room are the ones that I am building my research off of and my work off of, is because the mental health area, dealing with serious mental health disorders, is kind of the health domain that laid the groundwork, or is the domain that laid the groundwork for digital phenotyping. When we think about it, we have studies that have shown that Facebook language predicts future clinical depression diagnosis, as well as using keystroke patterns. Typing on one smartphone has the potential to predict manic episodes and bipolar disorders, as well as geolocation data. Geolocation data can be used to associate with depressive episodes and relapse of schizophrenia. We also have accelerometer data, and things like call and text logs can predict social anxiety symptoms and distinguish between depression and affective disorder. So if you think about this, this has laid the groundwork for the work that I'm doing with using substance use disorder. And here are just some of the kind of like the trajectory of some of the work that we did in the lab. You know, does this click too? Yeah. No. Okay. We will keep trying. Starting in about 2015, we used web searches to track interest in synthetic cannabinoids. Then we moved to around looking at social media language on Twitter, using that to see if we can predict excessive alcohol consumption at the county level. So here we're taking social media language predicting alcohol consumption. Then we moved to using passive data from people being on a smartphone recovery app, and we use that and looking at engagement in that app to predict relapse. Again, these are people who are just living their life, and we're able to collect this data and then make predictive analytics. Then one of the other things we did, which was talked about earlier, is using linguistic predictors in SUD treatment retention and treatment outcome. And then sorry, I'm having problems with the button. And then we've kind of moved to looking at how we can use AI, for example, to predict treatment dropout, making a risk score, but also using it in alcohol liver patients with alcohol use disorder, using digital phenotyping to predict cravings. And finally, what we've been working on is using large language models, specifically in depression and suicidality, looking at the racial bias that's inherently baked into these models, and if we can, quote unquote, bake it out, as well as evaluating generative AI in a clinical setting and using real-world prompts and real-world questions. How well does it do? So first, I'd like to discuss one of the studies of kind of using passive sensing and real-time behavioral tracking. In this study, we had and it was published in Neuropsychopharmacology, we applied digital phenotyping, passive data collection methods to see how well we can do at predicting treatment dropout rates in relapse. And again, relapse is a very important, and treatment dropout is a very important thing to look at. 2 in 3 patients relapse within 30 days of entering treatment, and about 85% of patients return to drug use within 1 year of entering treatment. Relapse and treatment dropout are unfortunately a common occurrence and is not something that is abnormal, right? It's a chronic disease. We know things like stress, negative mood, craving, things like that are related to substance use disorders, treatment dropout, and relapse. We also know that, I mentioned earlier, kind of that ecological information gap. When we're assessing a person's risk or triggers or their cravings and things, a lot of times it's not at the time that it actually happened. So it would be great if we could have data that was collected while a person was going through things, and then being able to use that information, that real-time data, at a different time. We also need that retrospective data that was collected, but collected in real time. And I think that this is where social media was great for this study, because social media is written in real time, but it's archived. So we were able to use social media language that was written 2, 4, 5 years ago, and use that to predict treatment dropout and treatment retention. I just want to give a little bit of an area for people that know Philadelphia. I started the study when I was at Penn, and we were working with treatment centers that were around the Kensington, Market, Frankfurt, these areas which were kind of known for having some of the worst hit in the area, with open air drug markets and things like that. It was a great population, and they were so excited to have us in, and they were very supportive of the research, and I do want to thank the community for allowing us to do this. It was one of those things that no one thought we were going to get done. You're going to go in and ask people their social media language, no one's going to say yes, and they were very supportive. We had 504 people in the study. The mean age was 33. It was about 60% African American, 67% men. This is just who attends typically those treatment areas, those treatment centers. And people had about 4 previous treatment attempts, and then just a variety of substances, the typical ones that people were there for: marijuana, cocaine, crack, and opiates. We had 2 simple research questions: how accurate is passive data in predicting SUD treatment outcomes, and can we create like a risk score predictions tool using these passive data? So to kind of just tell you a little bit how we did this, a person came on intake. In the first week of intake, what we did was we did the ASI, the Addiction Severity Index score, which is a typically done thing to determine a person's severity. We'll look at how predictive it was. But we also, at that time, asked people for their Facebook language. We used the Facebook language of 2 years before entering treatment. So this is not looking at any of the language during treatment, it's looking at the language 2 years before treatment. So that is our passive data there. They wrote this 2 years before they entered treatment. So we use that, and we use large language models, and what we're going to do is we're going to predict out 90 days the likelihood of a person relapsing, staying in treatment, and dropping out of treatment. And considering that I'm here, I think you probably know what this next slide is going to show, is that the ASI did worse. You know, it didn't do as well as using the social media language in predicting relapse, dropout, and abstinence. But I think one of the key pieces here is when you combine the ASI and social media language, we see that we're getting different things. What the social media language brings is different than what we got from the ASI. But the social media language, I mean, we were very excited that the social media language alone did such a good job in predicting these outcomes. So when we evaluate it and we think about our second research question pertaining to can we use passive data, can we use as a tool, as a digital phenotype to predict treatment dropout? Can we make this as a kind of a treatment score, risk score? And here what we did is we did a clinical simulation. We took part of the data that we had not used already, and we said, okay, let's say that at treatment intake, you have the ASI, basic demographics, just like everyone else. We always try to beat demographics. So you had the ASI, you had demographics, and you had their social media language. How well can you predict if they're going to drop out of treatment in 90 days? And here we have an AUC of about 8.81. So in my area, we think that is a great ASI, a great AUC of being able to predict the likelihood of dropout. But to turn that into kind of like an actionable number, we would have been able to predict 79% of the people just at day one of treatment intake who would have dropped out in 90 days with their social media language, the ASI, and demographics. I don't expect people to stop using the ASI and only use social media language, and I think the key part here is the why. Why did we want to do this? Is that if we can have a tool, something as simple as social media language, we can then decide how to triage treatment. Remember, treatment is limited, resources are limited. This could be a way to kind of triage, how do we triage treatment? So what in the language was predictive? That's always the million-dollar question people want to know. And I'll briefly go over it. You guys already, this isn't going to be earth-shattering. Positive emotion, family, affiliations like friends, ally, the more first-person singular pronouns they use. These were all people that were more likely to stay in treatment. Using articles, those people using articles were more likely, you know, kind of like A and the were more likely to discontinue treatment. I think the key piece here is the protective factors. And we also saw this in kind of looking at topic modeling of word choices. You see things like religion, like prayer, family, friends, things like that. One of the key pieces, remember that this was mainly a male population, and we found that mentions of positive mentions or positive terms of mentioning female members and enduring terms was associated with staying in treatment, and we saw that versus not using positive terms relating to females. And we think that that was just like a little bit of a sign of social support, more than likely. And then as far as for negative language, what we see was very odd in the sense it was like much more varied a language. People were talking about daily life activities. They did talk about pets a lot, and they talked about neighborhood violence. We weren't really that sure how to make up the negative, the discontinuation. One of the questions that we kind of had was maybe it was a little bit of treatment matching, maybe being an intensive outpatient that long for people who dropped out, they had other things that they wanted to do, not really that sure. So kind of thinking about this in a summary, just to put it all up at one time, is that we were able to predict treatment outcomes using kind of this passive data. It did capture something different than the standard measure. we could potentially use something like this as a screening tool, and then we can see that there are different language use of people who did well in this type of community-based treatment center. Now, one of the next studies I want to briefly go over, we use passive sensing in a population of people with alcohol liver disease who also had alcohol use disorder. And this is a great population to work with, because when we look at this population, ALD is the main cause of liver-related mortality and morbidity, and 75% of the patients with ALD, alcohol liver disease, also have alcohol use disorder. And we know that if you stop using alcohol, you have an improved life expectancy, and you a lot of times can regain functions of your liver. So it was in this right here, we did this with our collaborators in Mayo Clinic. They were adults. We recruited people from the EHR system, flyers, advertisement, things like this. We had a typical inclusion-exclusion criteria, and we kept this very light and very simple. They put our app on their phone, and we just wanted to passively monitor them. At the initial visit, we collected demographics. We also did basic kind of assessments you would do, and put the app on their phone. And one of the main research question here was which smartphone sensors features are more likely or more effective in predicting alcohol craving. It was really a pilot proof of concept. And as you can see, I think we had like 1630 patients, but everyone, all the things are different. So people from each of the phones, especially iOS versus Android, you get different sensors and different type of information, which makes analyzing the data really hard. But two areas that we saw which were predictive or passive sensing, for using passive sensing for alcohol craving. One was location entropy, which is the amount of time a person spent at a significant location. And what we see here is that over 30 days, and so this is location entropy of the day before, and some other people have seen things similar, of looking at the day before, and we looked at this over 30 days. We observed that days with positive changes in location entropy, indicating that time spent at various locations, were associated with a decrease in craving score compared to the previous day. And conversely, days that had negative changes in location entropy, indicating that less time spent at significant locations, were associated with an increase in craving score. We also, one of the other sensors or features we were able to extrapolate, we looked at accelerometer magnitude, which is basically the detection of movement in a day. And here what we see, there it is that the days with a decrease in accelerometer magnitude was associated with a decrease in alcohol craving the previous day. And conversely, days with an increase in the average accelerometer magnitude was associated with an increase in alcohol craving score. So, and again, we didn't use EMA. We did use EMA also because we asked people about their daily alcohol craving, but we mainly relied on, the passive sensing and then confirming it with EMA as the outcome. And I think that the summary of this is that we could use sensor data in a clinical population, a highly clinical population, look at alcohol craving. And also the implications of this is that smartphone sensors can serve as surrogates for craving. Preliminary, that's a little soft, I may be stretching a little bit, but it can potentially serve as surrogates for alcohol craving. How are we on time? Okay, good. So one of the things I mentioned was looking at kind of the ethical concerns that we have here. And we have a lot of ethical concerns, right? Especially in the population I'm working with that is the behavior that they do is highly stigmatized and criminalized. And we're asking for all this information to come through on their phone and their devices about location, what they say, what they do, and we could potentially be putting them at risk. And I think that that is one of the main concerns of collecting this passive data, is that it inherently involves a continuous tracking of individuals. So as we build tools, we have to make sure the way we build it doesn't put participants at risk if their phone is confiscated, for example. There's also the issue of bias and fairness. Passive data collection relies on devices and platforms of individuals, but mainly sometimes the platform itself of like Google and iOS or Android and iOS allowing us to have access. But just the point of saying that we're going to be collecting it off of these digital devices mean that a person has these digital devices and has access to them, and that they're in safe environments where these things will not be taken away from them. So there is an inherent bias and fairness of doing this. We also have the question about autonomy and agency, which is, I think, a very important thing of looking at, is that if we can predict these high-risk behaviors, again, which are illegal in many areas, and potential relapse, how do we ensure that we're not being coercive in doing this, but also that as we're talking to individuals and we're projecting about communities and things like that, that we are allowing the communities to have, like for example, if you collect data from a group of people in a certain area and then you say, drug use is happening in that area, partially is because that's where you collect it. But thinking about the autonomy of individuals, to making sure that they can say yes, making sure they can say no, making sure we're not being too invasive in the individual, but also invasive in the communities where these individuals live. And I think finally, we want to talk about accountability and oversight. When people allow us to, I'm basically like what the CIA, or their cell phone and their internet connection and all the stuff that they're doing, we have a responsibility of accountability and oversight. And I will say this, I know the NIH wants us to do data sharing. A lot of this stuff we can't share. There's no way to really kind of de-identify. I mean, you can do some simulation and different things, but it's really hard. And so we have to understand that we are stewards of this and be very respectful and have serious oversight when we're sharing or when we're working with this data. So I would like to thank everyone for coming along on this journey with me. I hope you had a good time. I hope this was inspiring. And I want to thank everyone. I also have to thank my current team of people in my lab. They're the ones who make the magic happen. And I'm very grateful. For example, Jessie Hemmons, my clinical coordinator, she's been with me since I got my first R01, as well as Sal. And so I'm just very grateful for my team, and also for the alumni that we've had in the lab and we've worked with. I love trainees, and I love the work that we do, and hopefully helping them to be great scientists. Lots of collaborators, current and former, that we've worked with. We're a collaborative lab. We have lots of data, and I always invite people to reach out to me, and we can start thinking of some research projects of data that we already have or data that we're collecting. We're getting ready to do a national repository of digital phenotype data that will be going out, hopefully to get 10,000 people, and love to collaborate and talk to people about that. And again, I have to thank my funders. I have to thank my scientific director as well as my institute director. I've always been funded by NIDA, and I am proud to continue being funded by NIDA. Thank you, everyone.
Thank you so much, Dr. Curtis. I would love to now invite questions. I can bring the microphone over to anyone interested. Get my steps in today.
Thank you so much for that fascinating talk. I'm Carther from UCSF. I'm curious, for the part of your talk where you talked about how LLMs were able to significantly augment the addiction severity index, predicting rates of relapse and dropout, do you have a sense of what factors you feel like the LLMs were able to pick out that weren't in the ASI? I mean, from my perspective, it seems like maybe it's picking up on socioeconomic factors or other things we know are connected to those kind of risks that aren't in the ASI, but I'm curious if you have a sense of maybe what it was finding.
I really think it was the religiosity as well as the social support. that you don't get with the ASI. Because the ASI, actually, it does do social economic status, and it has past drug use history, criminal history, mental health. Those are all part of the ASI. But what it doesn't have is someone's like religiosity, how connected they are. Remember, these were community-based treatment centers. These were 12-step like type community centers, which that's why I kind of alluded to. I think a little bit of this could have been treatment matching, that people that felt comfortable where you're talking about a higher power all the time, they did better in treatment. So I think that it was more of like kind of those pieces of language is what it picked up: the religiosity, the positive, negative emotion, and the affiliation with the female, like speaking of positively a female, which I think was just having social support.
Thank you, really interesting.
I had seen someone have their hand up. Okay.
Thanks so much, Dr. Curtis. This was a great talk. I actually want to rewind all the way to the beginning of your talk, where you were talking about these ideas of if we digitize, psychiatry and psychology and treatment, are we losing something? Do we not have the relationship? Those types of things. And I guess my question is, are we afraid of this thing that we don't know is actually going to happen? Because when we look at some of the digital interventions, like there's some out of the UK, where it was literally just an app to catch if somebody was going to relapse, they found that at the end of treatment, those people developed a therapeutic alliance with those apps that were not designed to create a therapeutic alliance. So much so they didn't even think to measure that. And then you look at sort of some of the VR headsets and things like that. So how do we start thinking about, are we freaking out about something that isn't really there? That we actually can have these therapeutic alliances, these can be done in ways that are engaging.
I think that we are freaking out about things, yes, that aren't there and that may end up being maybe very important. When there's I went to Annenberg, and there was a professor there who wrote a book about when old technologies were new, like the invention of when the phone was introduced and all the hoopla that happened, or when electricity enters home. Whenever something new enters the market or the world, it's disruptive, and we're very concerned about it. And then we end up learning how to make rules and how to live with it, how to regulate it. Small r, not the big R. And so one of the questions or one of the issues that we have is I think we need to be mindful, because one of the things with substance use disorder is it's a very lonely, stigmatizing thing, and so you do want people to have interaction, but we should not be afraid that people may have interactions with their device. For example, when you live in certain communities, leaving that door is putting you at risk of so many things, right? So maybe you should stay in the home and kind of talk to your device. That may be the safest place for you. What we need to figure out is, if we're doing this, can we also monitor maybe if a person is having too much reliance on the AI, that we can then prompt them or prompt other people to come into their lives? So I think we need to start also measuring what is too much or what's not healthy of being too much. So yeah.
I had a more technical question for your work on using LLMs. That was really fantastic. I was wondering if you could say a little bit more about how you use them. So were you extracting features, or was it more prompt-based
okay.
work? Yeah.
Most of the studies I showed today were all feature extraction, either using a data-driven approach or using an open vocabulary approach. But we do a lot of prompting, and that's a whole nother for our generative AI part. Yeah. Yes.
Well, thank you so much for this talk and doing this work, particularly in this population. I work in an intensive community-based program in Baltimore, where we focus on a lot of these patients with complex dual diagnoses who have serially relapsed after multiple episodes of treatment. And if I had access to your social media analysis tool at intake, would be invaluable, because we'd wrap additional services around those patients and probably keep them in our intensive program longer. But I also worry about potentially darker uses of that data that would label individuals as potentially resistant to treatment, and therefore identifying treatment as potentially futile going forward. And I'm just curious what your thoughts are.
So so two things happened when one of the first times presenting this data. That was one of the points that came out, is that it could allow people to pick better people to take in. And you think about the way that some of the city-based, at least I know in Philadelphia, the way they're funded and they get more money based on who they can retain. So there's like this kind of financial reason to have people that are going to do better in your treatment. So that is a concern. It's obviously a concern. And there's also kind of this concern that, and the idea of doing no harm when you are getting data about a population from a community, how much harm do you know, because people extrapolate that to the rest of the community. And making sure that as we build these models, that we are very accurate and attentive, and as we publish it, saying this should be used this way and it shouldn't be used that way. But we have no control once you put it out of how it shouldn't be used. But it is a concern. Thank you.
Hello, my name is Brian Benson. I'm an addictionologist serving Louisiana and Mississippi. Desperately need solutions like you've described here. Wanted to know if you had any ideas as to how we can use technologies like this to determine root causes for addiction, and also if there might be some way of determining the potential for an accidental overdose, maybe some compulsivity score or something like that.
So we do have, for our overdose, and we have several papers where we've done forecasting as well as predictive analytics, looking at more at an environmental level. But we did get access to some of the restricted data, and we've been working with that, looking at what are the parts of an environment or a community which can make certain communities more susceptible or more likely to have different levels of overdose. And I can point you to some of those papers. And we also have one that's on its way out, where what we did, instead of looking at county by county, which was what we typically did, we used the Americans Community Index, which looks at similarities of counties. So not necessarily where a county is, but for example, the African American South, Hispanics hub, the Latter-day Saints communities. And so it looked at similarities with communities by their SES, their voting patterns, all these different things. And it's amazing what we're seeing of which communities are affected by overdose and which ones we're able to forecast. So you can, for example, be part of this community and maybe these three are having high levels of overdose. The forecast is that you need to look at these other ones because they're on their way to have high levels of overdose. And I'd love to share that with you. Thank you.
Thanks.
So we're doing this at like the individual level, but also at the community level.
Hi, thanks for a great talk. I wonder if you have had interactions with or could talk about the large social media companies and their relationship. Because I remember hearing years ago, and I don't know if this is accurate, but that there was concern among some of the big companies like Facebook and Google and so on, because if people thought that they could predict things, suicides, overdoses, and so on, that would then incur responsibility or even liability on them. And I'd been told at one point, I think, that there was a committee in Silicon Valley where these guys got together. And ultimately, I do think they have some responsibility, but I'm particularly around their algorithms, but I'm wondering how that interfaces with your work or what you've heard about that.
So yes, when Facebook first did that emotion contagion study, and they kind of got in trouble when people found out what they were doing of how to manipulate emotion, they closed all of their APIs down for researchers and most people in order to use the devices. We met physically with Facebook. We showed them what we were doing. We explained what we're doing, how we had consent, and they kept our API open so that we could continue collecting data. But as of last year, we're still in 2024, but as of like 6 months ago, they've completely shut everyone off. So basically now there's no one to, kind of mind the hen house, right? I'm answering your question a little bit differently. Right now, we do not have direct access. So that study I did, I kind of can't do it right now because they are not giving, Twitter closed down, Reddit isn't allowing you to get their API, Facebook isn't, so there really isn't anyone. So what we did, because I kind of saw this coming after the first time, is we built our own app that the passive sensing, that it does keystrokes. So we get, no matter where they're at, Snapchat, Tinder, anything, where they're at and they're typing, what they put in, but that's only from when they start the app, so I can't get the retrospective data. So do I think, I'm not going to answer because I'm a federal employee, so I'm not going to answer if I think they have a responsibility. Yeah, I'm going to stay clear of that one, but.
I know we had one question. I think we have time for maybe one or two quick ones. Maybe you two.
A fantastic talk, thank you. So going back to the LLM work and the 2 years of data that was acquired, I'm just curious, did you have a chance to look at how heavily weighted the more proximal time frame versus the more distal time frame was in the accuracy of the predictions that were being made? I think one of the concerns that keeps coming up in the questions is there's a great deal of responsibility with the more longitudinal data, individual data that's acquired. And so I guess my question is, what's the minimum amount of individual data you need out of that 2-year window to have a good predictive strength?
So we had the data since they had their account, and we looked at all of it. And we found that looking at 2 years versus 5 years versus 7 years didn't do any better. So we decided to stick with the 2 years. What was more important is the person needed to have enough language to analyze, and that was what was a little hard. We've worked with past studies and many other people. We found that having at least 200 words on Facebook or on your social media is the minimum that we need. But we were fine 2 years versus 5 versus 7 versus 10. It didn't do a difference. So we went with the 2 years. Again, your mileage may vary because times have changed and no one's on Facebook, but yeah.
This was a lovely presentation. I just have a very quick comment on the Facebook side of things. And I can say this because I wasn't the one that signed the NDA, and I don't work for the federal government, but there absolutely was and is very adequate power inside of Facebook to be able to do a really good job predicting suicidality, suicide attempts, and things like that. And prior to just post the Kramer PNAS paper, they quashed that work and didn't allow it to get out my lab.
And it's what I've heard is that they can also, having data of your friends, be able to very accurately predict you.
Yep. So
This is what I've heard.
There's a lot of capacity that is no longer available to us as researchers.
Yeah, they used to let us come on their campus and analyze their data, and now we're not invited anymore. But they would squash our studies if it says something that we didn't like.
Yeah.
Great. Well, I'd love to take a moment again to thank Dr. Curtis